All right. Good evening, everyone, and welcome to tonight's surgeon education webinar on dural challenges and CSF leaks in complex pediatric spine surgery. This webinar is bringing together leading pediatric spine surgeons to share practical strategies, real-world cases, and actionable techniques for preventing, recognizing, and managing CSF leaks. And it really has a focus on decisions you can apply in the OR and postoperative setting immediately. Next slide, please. My name's Arun Hariharan. I'm a pediatric spine surgeon in West Palm Beach, Florida at the Paleo Orthopedic and Spine Institute. I'll be co-moderating with Dr. Sukin Shah from Nemours in Wilmington, Delaware. We're glad to have you here. And Dr. Shah, great to be doing this with you. Tonight we have 5 faculty. They're all leaders in pediatric spine and neurosurgery from a variety of backgrounds and research interests. They're going to be covering this topic from every angle. We have Mike Glotzbecker, Steve Hwang, Taemin O, Dan Hedequist, and Pat Cahill. Quick logistics about the webinar. Please submit all questions to the Q&A function in the Zoom. And after each presentation, the moderator will pose questions to the speaker, and we'll try to get through as many of these as we can in the time that we have. And here's the rundown of the show. We have 5 back-to-back presentations, each followed by the Q&A. We're aiming to be done by 6 o'clock or 9 o'clock, depending on where you are. So we'll keep things moving. There's a lot of ground to cover, and we don't want to shortchange any of these talks. You'll hear from Mike Glotzbecker on incidence and risk factors, Steve Hwang on intraoperative management of dural tears. Taemin O would be presenting on the post-op management of CSF leaks and pseudomeningoceles. Dan Hedequist will talk to us about quality and safety protocols and preventing these leaks. And then Pat Cahill will round us out on case-based pearls, including some more of the nuanced scenarios. Tonight's webinar is brought to you by the Setting Scoliosis Straight Foundation. It's the nonprofit arm of the Harm Study Group, established in 2018. And the goal really is to advance discovery and education in pediatric spine deformity in all realms. If you find value in tonight's content, I'd really encourage you to explore all the resources available at settingscoliosis.com. And before we begin, we have a brief word from our webinar sponsor, Baxter. We're really grateful for their support in making tonight possible. Alicia Heredia, the territory business manager, will share a few words with us.
I want to thank the Setting Scoliosis Straight Society and Dr. Shaw for the opportunity to sponsor this webinar. I've had the opportunity to partner with Dr. Shaw and his team in the OR for about the last year. And today I want to highlight how Baxter partners with surgical teams every day, not just through adjunctive hemostatic solutions, but by supporting education, workflow, and consistent patient care across the entire surgical continuum. The reality is, patients bleed. Leaks happen. There can be unforeseen circumstances in the operating room. Across surgical specialties, bleeding is a common challenge that directly affects outcome and efficiency. Uncontrolled bleeding can prolong procedures, increase complication risks, and length of stay. These consequences are especially detrimental in the pediatric population. Surgeons need adjunctive tools that they trust and a support team that understand their day-to-day challenges. And that's where Baxter comes in. For more than 45 years, Baxter Advanced Surgery products have been trusted by surgeons and hospitals. We offer a comprehensive portfolio of adjunctive hemostats designed to support surgical teams when traditional methods are insufficient. Our focus is reliability, usability, and consistent performance across procedures, backed by extensive clinical evidence and a legacy of trust in the OR. But it's not all about products. What truly differentiates Baxter is partnership. We work alongside surgical teams to understand their workflow and help integrate solutions seamlessly into practice. This happens through education. Surgical teams no longer need to rely on the products you were trained on or what we've always used anymore. Through education and understanding the right product for the right bleed, hemostatics can be a targeted tool, helping ensure appropriate product use, reducing waste, increasing confidence, and supporting consistent practices across the OR. By pairing effective adjunctive hemostatics with education and support, Baxter helps hospitals improve efficiency while maintaining a focus on patient outcomes and clinical confidence. Baxter reps strive every day to be a trusted partner in the OR. Our company motto is, "We stand behind the hands that heal," and I try to emulate that every single day. In the interest of time, I've included a few slides on products that are most applicable to your teams. Harvey has a copy of this full presentation if you want to read more. However, I strongly encourage you to reach out to your local rep. Baxter reps are always available as a resource, both in and out of the OR. Feel free to reach out to me and I'll connect you to your local rep. Thank you so much for your time, and thank you for allowing Baxter to continue to stand behind the hands that heal with a shared commitment to excellence in surgical care.
Thank you so much, Alicia. Appreciate the presentation and your partnership in the operating room.
So let's get into it. Before we start, I just want to spend 2 minutes framing why this topic is so important and unsettling. CSF leaks are known complications in spine surgery. The published incidence is somewhere between 1 to 4% in pediatric surgery. And we think that half of these cases are recognized postoperatively when your options are more limited already. And despite the fact that every surgeon tonight has encountered this, there's really not much published consensus guidelines on management of this in any scenario. Next slide, please. So we tried to answer that and did a survey among harm study group members. And you can see here on the numbers why this webinar is so important. 81% of the harm study group members said they were only somewhat confident in their own management. These are people with more than 10 years of experience and who do 100 or more cases a year in a vast majority of them. And half reported no standard guideline on postoperative leak management, and only 41% routinely involved surgery, and a vast majority of them, or about 3/4, had difficulties in areas of uncertainty of lumbar drain usage and re-exploration thresholds. So I think tonight's faculty is really going to address all of these, and without further ado, let's get started. So first speaker is Dr. Mike Glotzbecker. He's a pediatric orthopedic and spine surgeon at Rainbow Babies and someone who has thought about this carefully for a long time. He'll be covering the incidence and risk factors of CSF leak. Dr. Glotzbecker, go ahead.
All right, perfect. So I thank you very much for the opportunity to talk tonight. And my task is to talk a little bit about how often this happens and some of the risk factors. And as Bernard already alluded to, the literature is pretty limited, but I think hopefully we can jump off from this standpoint. These are my disclosures, none relevant to this talk. So the plan tonight is to talk a little bit about how we define what a CSF leak is, because I think how you define that really determines what we're going to consider to be the incidence. With that in mind, we'll be able to sort of talk a little bit about incidence in different scenarios, and then ultimately some risk factors for it. So we'll start with definitions, because I think this is really important on this topic. We have to define what we're considering as far as procedures and their relative risk with regards to CSF leak. So, the first situation is an intraspinal procedure, tethered cord, often performed by the neurosurgeons, intraspinal tumors. This is where you have to open up the dura and close it. And this is going to have some degree of risk that's different than other scenarios. The other, I think, category that we have to think about is myelo patients. And this can be very early when they have their closure, but also later when we have to do their spine fusion and they have an open canal and they have scar and they have difficult soft tissues. And so this presents a different set of challenges. This is probably for the idiopathic scoliosis surgeon, potentially the most common, so the incidental intraoperative. And this is probably underreported. So, for me in an idiopathic, this is a sonopet or a bone scalpel during a pontiostiotomy getting into the dura, or using you're all getting into the dura, or when you're decorticating and you get a little bit too close to the dura. So again, this often is identified and then repaired, so it probably is not reported as much as we probably would think. And then the last category, which is pretty rare, which is the one that's tough to diagnose, and I think some other talks will address this, is sort of the implant or delayed in where the screw is in the canal or something is sort of done during surgery that's not recognized and then it comes up later. And so what is the incidence? Well, this is a summary of the evidence. It's very low in pediatric surgery, so there's not a lot of studies that actually talk about it, but I think we can glean some from the studies that are out there, as well as some of the adult literature. So there's only one or two really pediatric series, and the incidence is about 3.3%, as Arun alluded to, somewhere between 1 and 4%. Intradural procedures, obviously, it's much higher. If you have to open the door and close it, it's going to be higher. As I sort of talked about, the incidental intraoperative is probably underreported, and then late or implant related is pretty uncommon and not probably common enough that we have true incidence. So in the one main pediatric study, it said that 69% of these occurred during exposure. And so you have to assume that that includes some patients with some difficult anatomy. The other sort of things that we do during surgery, putting the awl in, putting the pedicle screw in, doing osteotomies, removing implants, all have a much lower. But, interestingly, even just doing intrathecal morphine had some risk of a postoperative dural leak. If you get a dural leak, you're at a higher risk of surgical site infection, just important to know from a sort of demographic standpoint, and about 35% of these will actually require a second surgery. So just sort of to give some demographics around it. So what about risk? So it's going to sort of follow what we just talked about from an incidence standpoint. So the probably number one risk factor in both adult and pediatrics is revision surgery. So if you look at index versus revision surgery, you can see the difference, from under 1% to up to 18% revision surgery for adults, and similarly up to about 6% in kids. I think the revision surgery in kids is a little bit different than adults, and we have to luckily do it a little bit less often. But we do have these cases of early onset scoliosis, autofusion, sort of other situations where the anatomy gets really difficult. And I think it does put us some increased risk. And because if you don't have normal anatomy or normal landmarks, if you're not sort of using some alternative tools, you may be a little bit more likely to get medial in the canal. Other risk factors in peds, dural ectasia, congenital or abnormal anatomy. I think the more we do with the spine, whether it be a Ponte or a 3-column, also increases that risk. So from a dural ectasia standpoint, if we think about things like neurofibromatosis and Marfan's, the pedicles are extremely small. The dura is a bit thinner, a lot easier to get adjacent to it. We all take care of in peds congenital scoliosis, and when the anatomy is really abnormal, I think you don't have your normal landmarks to go to, and so your chances of getting a bit medial are certainly increased. And again, if you're looking at spines like this, you're not looking at things that you're going to be as comfortable with on a daily basis. And some of these kids will even have, even if we say they have dural ectasia, really small pedicles, they'll actually have even absent pedicles. So, if you don't know about that pedicle and try to put a screw into that pedicle where it's actually missing, chances of you hitting the dura are pretty high. Sometimes there's snakes in the grass. So this is a kid that I took care of that I thought had idiopathic scoliosis. On hindsight, looking at the bend films, the pedicles looked really thin. I had a really tough day getting pedicles into this kid, but you can see this kid didn't actually have dural ectasia, but the pedicles are tiny. And so if you're trying to put normal screws into those pedicles, you can get in trouble. And this kid actually showed up a bit later. You can see I had a medial breach. I had to sort of bail out with hooks. And this kid, which we'll hear about a little bit later, how you diagnose and treat it, but this kid showed up at 6 weeks with a delayed dural leak. And it's probably because I was in the canal probably at multiple levels without really knowing it. And then, again, we do this routinely, or a lot of us do this routinely for idiopathic scoliosis, even just doing a Ponte, you're in the canal. And so you're taking the ligamentum out, you're removing the superior articular set. You may do this with a Kerrison or a rongeur, even the bone scalpel or sonopet, but all these maneuvers are adjacent to the dura. We're looking right at the dura. And I would say this is my most common time that I've gotten into the dura. Is sort of with an inadvertent durotomy by using sort of during the Ponte process. And a lot of these images are from Sukin as well, or one of our moderators. But, again, the canal is open at multiple levels. And again, for those that do aggressive releases, this is going to increase your risk. And then I think if you look at adult risk factors, they tend to have more trouble, I think, with the dura, just it's thinner and they have some more complex things. But osteotomies, doing a laminectomy, lumbar surgery, and increased surgical invasiveness all increase your risk, which sort of makes sense. And so as we get into more complex osteotomies, 3-column osteotomies, pedicle subtraction osteotomies, vertebral column resections, you're doing 360 resections where you're around the dura the entire time. These things are all obviously going to increase that risk of a dural injury. So key takeaways as far as incident risk factors, I think there's really truly limited literature on the true incidence in pediatric patients. I think this is especially true in deformity. It's a little bit more clear in sort of the intradural and the myelo patients. But again, that's sort of some unique populations. I think the risk factors sort of make sense. Abnormal anatomy, including both congenital anomalies as well as dural ectasia. Anytime you have to go back, it's going to increase your risk. And I think the more you do around the spine and the more you work around the dura, the more likely you are to get into it. So thank you very much, and open to questions.
That's excellent, Mike. I don't see any questions in the Q&A right now for you, but I'm sure they'll come a little bit later. And thanks for the excellent talk regarding the risk factors. I think, one thing that's underemphasized is certainly the dural leak on exposure. Might be sometimes with our assistants, sometimes maybe people not paying attention, sometimes with anatomy that's unrecognized with a defect in the midline. But the revisions certainly, I think that's where we have the most trouble. The anatomy is very bizarre, and we expect to see bone covering the canal, but that's not always the case. All right, we're going to continue with our program. Dr. Steve Hwang from Shriners Hospital in Philadelphia will tell us about intraoperative dural tear management and recognition.
Thank you, Sukan. So I guess I have a dubious honor of being one of the experts, and unfortunately have a lot of experience with CSF leaks. So no disclosure is relevant to this talk, aside from having fair experience with repairing durotomies, many of my own. So this is an example of a 14-year-old girl, hypoxic encephalopathy with a pretty big stiff curve. I chose to do an L1 VCR with her, thinking to get more correction, which may have been the first mistake. But we did get a ventral durotomy doing that. And that became a big hassle. As Mike kind of talked about, she actually healed okay, but she had an infection post-op and needed more revision surgery. So I'll talk a little bit about how I manage it. So the first thing I tell most of our fellows is just don't panic. It seems like all this water is pouring out, or CSF. The first thing, you kind of freak out a little bit and just let it egress, stay calm, let the CSF come out. I put a patty. You just don't want the nerve roots to herniate. So I put a ball tip or something to prevent them from herniating out and getting kind of tangled. Just don't want them to look kind of like all jumbled up in the bottom left. And then just reassess. I look at, do some nerve monitoring, make sure things are okay. Typically it is. Check the size of the opening, the shape, location, exposure, and I'll touch on each of these in a little bit in more detail. So my general approach, as we talked about, there's not a ton of literature on how to approach this. I tried to formulate it into kind of an algorithm, although this is with a caveat that I don't really have a set algorithm. So, it does happen I've had an opening, closing, even the middle part, but during the opening part, if it happens, I kind of try to repair directly. So if it's the dorsal aspect, the lamina, I'll try to take some more bone, find, clean borders, and then repair it if you can, or patch it potentially. If I see it with a screw placement, I tend to just put a little bit of a flow seal or something to seal the hole, and then wax over the top of it. And then I just kind of avoid doing a ponte there, trying to avoid creating a big open space in that area. And generally that's worked well. There's not a ton of literature. West et al. Published a small series with 3 patients in that series and treated the same way and did okay. And if I get a bit of a later leak, it then depends on the location. If it's dorsal or lateral, I try to do the repair. If it's more ventral, I try to make a little bit of a burrito, which I'll go over. I kind of wrap the ventral surface, put a little glue, and may consider, since you can't repair it, more of a drain. And so people have published a little bit. There's one series from Penn that published their experience, and largely they talked about repairing primarily, maybe using a muscle flap or fat, using a subfascial drain, which I think is very, very important in these cases. And if it doesn't work, then come back in, re-explore, and put a subarachnoid drain. If it doesn't work again, then maybe do a permanent CSF diversion maneuver like an LP shunt or VP shunt. And so I have a pretty high threshold to avoid a shunt, especially in kids, because it's kind of a permanent thing for the most part, and it can carry certain morbidity long term. But the algorithm, I think, is reasonable. So when I first approach it, size doesn't matter in this case. If it's a small little tear, you can put a figure of 8, repair it primarily. I tend to use 6-0 Gore-Tex sutures, just because the suture itself is a little bigger than the needle, so it kind of plugs the hole as you go through. But it depends on whatever your preference is. If it's a really long opening, you may want to dissect more bone, and then depending, run a suture through it or do a patch. The suture type, again, often in neurosurgery, we use fluoroneurons in general, but I've switched a little bit more to the Gore-Tex. A lot of my colleagues are using clips as well. It's just tougher to use a clip with an irregular tear. So if you have a clean opening, it's fine. But if it's incidental, it's a little tougher to use that. But there's some data that actually works pretty well and is actually pretty strong compared to sutures even. And this is a small series of tumor patients. They actually had fewer leaks using clips than suture. But again, that's a very controlled linear opening. And as Mike said, like the etiology is a little different versus incidental durotomy versus access opening. And so the opening again kind of matters a little bit. If you have a direct thing you can repair, I would try to repair it primarily. If it requires a lot more work to try to get to repair, like a pedicle screw track or something, then I tend to take the path of least resistance and just kind of seal it a little bit. Again, if it's very irregular, you may need to do a patch and sew edges together. Or if the quality of dura is really bad, as Mike talked about, you have a dural adhesion in F1 patient. I just find it's hard to suture because it just tears. So I'll cut a patch out and try to suture the patch, not to tear the kind of native dura in that case. I tend to use alloderm, but there's a lot of different substitutes you can use. The kind of the burrito on the bottom right is I have a ventral tear to illustrate that kind of I wrap the dura and then I suture the top or suture to the sides of the dura and I try to put some glue in it. In terms of the double dural substitutes, there's not a ton of spinal comparisons. We have a few head-to-head comparisons cranial, but it's also a little different because the leak rate's a little bit lower. The posterior fossa, like Chiari type stuff, is probably a little more analogous because it's kind of gravity dependent and it has a higher CSF leak rate if it's not a tight closure. But really, some slight differences, but not a clear kind of winner overall. In some series, algorithms do well, but really, I think it depends on your own personal preference, what you have available, and what you're used to. If you do use the algorithm, I would suggest you use the medium. So you don't want it too thin, but sometimes the skin pores can pop through and then you just have another leak. And then location matters, as we know, kind of cervical, thoracic, lumbar. The lumbar area, you have a little more redundant dura, so it's easier to put a stitch and figure 8 to close that. You may be less inclined to do that if it's cervical or thoracic. If it's anterior, again, I do that kind of burrito wrap technique and suture dorsally. I had a recent case, and I just was worried about ventral compression, so I sutured it to the lateral aspects of the dura, a little bit of glue. But ideally, if I can do a direct repair, I prefer to do that. And then if I'm really worried that it's not a tight seal, I'll put in all the extra stuff. So the Duraseal for Bridging glue and kind of step it up a little bit. In terms of which sealant to use, there's not a ton of data again. They seem equivalent, so use what's easiest for you. It's accessible. Some of them are quicker to mix, so you can just access it. But they overall seem fairly comparable. And then peri-op, some of the post-op management, I think Taemin's going to talk about, so I won't touch on too much of that. But I typically put a drain in if I'm very worried, but usually just a subfascial drain. A lumbar drain, I'll kind of escalate if it's a take back or if I'm really worried about something just being really torn up and I can't primarily repair it. So my kind of go-to is a JP drain. There's one small series looking at this with an N of 8 that had good results, and then a Chinese paper from Hwang et al. That looked at 100 patients, and they actually looked at different groups of how long to leave the drain in subfascially, and found the pressures decreased after about 7 days. So I typically do a subfascial drain, thumbprint suction, and just make sure I don't pull more than 300, 450 cc's, which is kind of on average, kind of an adult equivalent of CSF production on a daily basis. Make sure they don't have headaches, things like that. And then after about a week, I'll clamp it, make sure it's not leaking through the incision, pull the drain, and put a figure-8 stitch through that site. And so I try to simplify it overall. It's not, there's so many factors that come into play, but generally if I have a nice low risk leak, so I feel like it's a small opening, I can put a nice figure-8 that closes it. I'll Valsalva, make sure I don't see any leak at the time of surgery. If I'm happy with that, I always do a running fascial suture now as well. That's something I learned from our plastic surgery colleagues. So the two main go-to things I have are pretty much a running fascial suture and then JP drain in the cases I'm more worried about. And then flatbed rest, I think Taemin will probably talk on this. I'm kind of back and forth on that depending on the risk overall. And if I'm worried that it's really not a good closure or they're high risk of leaking, bad dura, then basically I'll kind of throw everything at it. I'll throw a patch, put the glue in, subfascial drain, and make him flat for a little while. And then if I need to escalate, I'll put in a lumbar drain. I kind of do more. Then I'll close the skin with the 3-0 running monocril on top of that to try to really prevent it from leaking out the skin. My general approach is if it doesn't leak out the skin, things heal. Unless there's a ball valve phenomenon with the pseudo, it usually won't cause compression of the neural structures and it'll be okay. leave it at that.
Awesome, Steve. Thanks so much. That decision tree you laid out is pretty important. The adrenaline certainly spikes when the fluid starts coming out. There's a couple of questions. One in the Q&A, it says, does anyone use fat as patch anymore? What's your experience with that?
So yeah, it's kind of on the algorithm. If I can't get a closure, I'll put fat or muscle. So let me just cut muscle on the side, stick it over the top, do the figure of 8 and tack it down over the hole. But if I can primarily repair it, I'll do a primary repair.
Okay, and then real quick, another question was clarification on if you see CSF on screw placement, do you open it up and try to repair it, or just pack with bone wax and hope it seals?
I don't. Usually I just check neuromonitoring, make sure it's stable. This is probably controversial. I'm sure others do it differently, but I put a little bit of flow seal just to make sure that take out the pressure of the CSF leaking out the tract. I wax it. Then if I was planning to do a ponte or some more bone work in the area, I just skip that. I don't do that. And then I move on, and knock on wood, so far it's been okay for me.
Okay, awesome. Thanks so much. If there are other questions, please put them in the Q&A box. We'll move on to Dr. Taemin. Oh, he's a pediatric neurosurgeon at Columbia University. He brings the neurosurgical lens to the post-op phase. And I think it's genuinely different from how most of us approach it. So Taemin, please take it away.
Thanks for the opportunity to talk about how I manage postoperative CSF leak and pseudomeningoceles. I don't have any disclosures pertinent to the talk, apart from the fact that this is just what I personally do. I think there's a lot of variations in terms of what people have successfully done, but I'll talk a little bit about what's been successful in my hands, at least. So when I think about managing CSF leaks post-op, I think it really just comes down to 3 main components, right? And the first and most important point for me is that really what you do in the before you leave the operating room will have the most profound impact on what follows after. So the reality, with spine surgery is that CSF leaks, they're pretty much an occupational hazard. We all get them. And I can certainly tell you, standing on the neurosurgical spectrum of spine surgery, we take care of a lot of patients who have very complicated intradural pathologies. And so CSF leaks are very common for us. So when I do run into a leak intra-op, I just really try to focus on getting through it as calmly and efficiently as possible. And so I'll slow things down, turn off the music, take my time to repair the leak primarily if possible, and even call in colleagues if I really need some help. And Steve touched upon a lot about this, but again, everyone has their own unique way of managing these leaks intra-op, but in my mind, the majority of closures come down to 3 components, right? The most important is to really try to get that primary repair. And I won't hesitate to make the exposure bigger if I need it. So if the leak is within a PCO defect or a Lamy defect, what that means is I'll make that defect even bigger so that I can really fully visualize and fix that problem. Like Steve said, I really like the Gore-Tex suture for the exact same reasons. The needle and the suture are very similar in diameter, so you're not creating a bigger hole. And I'll typically put a muscle patch to tamponade that leak. And then that's followed by this onlay. And I don't know how many people have seen this yellow onlay before. This is called Taemin. And it's ever since I've started using this, it's really had a dramatic effect, at least personally, in terms of the complications of CSF leaks that I have had to manage post-op. And then you typically finish things off with the sealant du jour. And this is controversial, but I always leave a deep drain, just like Steve mentioned. If a patient has very high BMI, or if it's a non-idiopathic patient, I will also leave a suprafascial drain and a Provena wound back. All these drains are placed to gravity. I place them away from the leak bed. I rarely place a lumbar drain up front, mainly because I really don't want to create that CSF dead space. And especially if you have a patient who has a low LIV, L4, L5, it's going to be very challenging to put a lumbar drain in. And for those patients, an EVD actually might be a better option. And so at that point, once all your closure is done, the clock and the timer really starts. And the success of your intra-op closure, I think, determines how much your patient's positional headache becomes really your headache. And again, this is just my standard post-op management. Everybody has a different way of approaching this. But when it comes to mobilization, there's really only one randomized controlled trial out there in the literature. It comes from the adult degen literature. And they found that there was no difference in outcomes whether you mobilize these patients early versus late. But I will say, I think our pediatric population is a little bit different. So I haven't really adopted this in my practice, at least. If the leak is low thoracic or lumbar, I still do keep these patients flat for about 2 to 3 days. If the leak is cervical, I elevate the head of bed greater than 30 degrees. And if patients start endorsing some positional headaches when they start moving around, I try not to read too much into it. Sometimes it's orthostatic. It might not necessarily be related to the CSF, but depending on how severe the symptoms are, this is when I'll either consider prolonging immobilization, or sometimes I'll even give caffeine to help temporize the symptoms. I do add DVT prophylaxis, especially if these patients are going to be immobile for a long time. And as all of this is going on, I try to pay real close attention to what's happening to these drains. And my philosophy when it comes to drains is that they're really a double-edged sword, right? So on the one hand, you really need the drain to help wick away all that fluid. You want that fascia to fully heal. It takes about 7 to 10 days. But on the other hand, if the drains are putting out CSF, you might create a CSF fistula, or you might, worse, create a direct conduit for bacteria to actually access that subbasal CSF. So my first priority is to really get that deep drain out of there as soon as I can. And for post-op day 1 or 2, I keep it in to avoid hematoma, and then I'll gradually pin to the shoulder over the next couple of days. And by day 4 or 5, it's out no matter what. And then I'm monitoring what's happening with the superficial drains and the wound vac as this is all happening. And I take them out typically around post-op day 7 to 10. I'm also monitoring wound tension very closely. There's a couple of other tools available. If there's ever a question about whether the fluid you're seeing is truly CSF, you can send a beta 2 transferrin test, but I don't find that the turnaround is really quick enough for us to make accurate and expeditious decisions. So I typically don't send this. The bedside halo test, not particularly specific, so I don't routinely do it. And if patients are dumping out 500, 600 cc, sometimes I do put them on Diamox to help them out. So here's just a couple of examples of how I've managed some of my patients. This was a 15-year-old syndromic scoliosis. We did a T2 to L4 fusion, got a CSF leak during screw replacement. Similar to Steve, I just plugged with bone wax, did a Valsalva, there's no leak. He's high thoracic, so I kept head of bed elevated. I left 2 superficial drains and a wound vac. And initially, you see these high drain outputs, which I think are actually pretty common in some of our syndromic patients. No positional headaches. And then I removed the deep drain on post-op day 3 because it was below 200 cc's in output. Incision looked great. And the superficial drains were all taken out on post-op day 7. This patient did perfectly fine. This is a different type of patient who might need a little bit more of an aggressive intervention. 12-year-old came in with 2 weeks of progressive myelopathy, acute inability to ambulate. He has this large T10 aggressive hemangioma, causing significant canal stenosis and core compression. And if you look really closely at that CT, you can actually appreciate there's some spicules of bone ventral to the thecal sac. So I already had a sense that this was something that was going to be a problem intra-op. And that's exactly what happened. I had a ventral dural tear as I was trying to take down that dorsal vertebral body. Was able to somehow get a primary repair with a muscle patch. I did put a Duragen sling underneath and then laid some dural sealant on top. This patient was kept flat for 2 days, deep drain to gravity, initial high outputs, looked clearly like CSF, but this did slow down over the next couple of days. Drain self-extricated on post-op day 4, no headache. But on post-op day 7, the wound started leaking, so I oversewed it with a nylon suture at bedside, and then placed a lumbar drain for 5 days, clamped it, and took it out, and he was able to go home. And then there's the worst case scenario where you do have to really, kind of put your suit on and run into the burning building. And so this is an example of that type of patient. 16-year-old, very complicated tumor history, lot of adjuvant therapy afterwards, developed post-lamickyphosis, and then developed progressive thoracolumbar scoliosis. So we put him in traction for 4 weeks, did a long segment fusion. Another patient who we had a CSF leak during screw replacement, plugged it with bone wax, and high outputs initially, but actually dropped down about post-op day 4. So we took the drain out in post-op day 5, discharged the patient, saw them back in clinic 5 days later. Everything about the incision looked great, but the superficial drain started looking like CSF. It was starting to get late anyway, so we took it out. But he did come back 3 weeks post-op with this wound. He has since reported a clear fluid leak. So I placed a lumbar drain, but he continued to have positional headaches. Wound never really healed. So I took him back to the operating room in order to fix this, and actually didn't really see any obvious leaks. So just laid down a bed of sealant on top, and we were able to get him through successfully. And then there's a last scenario, which is the delayed postoperative CSF leak. And what I try to do for these patients is I try to essentially reassure the family in most cases. As long as they're not having a positional headache and that wound is not tense, usually you can provide some reassurance and carefully monitor. If there is a headache, you should think about getting a myelogram and refer for a blood patch. If the wound is tense, tap and wrap, put an ACE bandage on, carefully monitor what's happening. If the wound is compromised, certainly be prepared to revise. So the key takeaways, I would say, is just set yourself for success in the operating room. The goal is primarily to keep that CSF contained subfascially, and the vast majority of our leaks we can actually resolve fully with proper management. So this is our team here at Columbia. Just want to say thank you to everybody and happy to take any questions.
That's awesome, Taemin. I have so many questions, but unfortunately, we've got to move on. I'm going to type them into the chat. And we'll go to Dan Hedequist from Boston Children's Hospital, who has some great ideas about preventing CSF leaks through quality and safety protocols. Dan?
Hi, guys. Thanks. Great talks, guys. So a lot of this will reverberate what's already been said. Why a quality program? Some of the things you're going to see can either live in epic documents you create, or they're just a thought process. And given the low frequency, a lot of them is just a thought process. But remember, these are low frequency problems that have a high impact. If you manage them well, things go well. If you don't manage them great, there's a super high impact to your patient. So talk a little bit about preoperative risk stratification, intraoperative standardization, surveillance, and quality improvement. So preoperative risk stratification, what Mike already talked about a little bit, revision surgery, the severity and type of deformity, dysplastic or absent posterior anatomy on exposure, planned osteotomies, like everybody's talked about. If you're going to be in the canal, you increase your risk of a dural injury, and high-risk fixation. So if you have really dysplastic absent pedicles with dural ectasia, really think about whether you should be putting screws there. So a simple checklist for me is, what's the diagnosis, right? We're going to have a much higher incidence in pediatric spine of dural injuries and myelodysplasia, or dural ectasia, neurofibromatosis, and Morphines. And if you have one of these diagnoses, you should really ask yourself as a simple checklist, do I have appropriate imaging? So on the right, you can see that's a bone MRI with synthetic CT. It's a myelo patient. You can expose the thoracic spine really quickly. The lumbar spine is all open, so then you got to slow down. The same patient, you can see there's no shield for your bovie in the dura, so you got to decide if you're going to go through that skin, or you're going to make paraspinal or an inverted Y incision. So appropriate imaging is really the most preoperative standard thing that you can do to try to avoid problems. Intraoperative protocol and pause points. So you want controlled execution during high-risk events, and pause points to confirm what your anatomy is during exposure, implants, what you're placing and whether they should be placed at certain levels, and about your osteotomies. So prior to revision, exposure through scarred tissue planes. Before you initiate your osteotomies, think about passes. Even bone scalpels can cut the dura. During pedicle cannulation and dysplastic or rotated anatomy can have problems. And then during implant removal and revision cases, you can see over on the right-hand side of the screen a growing rod which is migrated into the canal. So when you take that out, you're at risk for taking out the dura as well. So revision cases, as Mike has mentioned before, really high risk of dural problems. So standardized dural repair readiness. I don't think as pediatric sort of spine surgeons we need a kit for every case, but if you're really going to do a myelo case or a high risk case where you're really worried about a dura, you should have these things available. You should have your absorbable sutures, your micro instruments, your dural patch, your graft materials, adjunctive sealants, cottonoids, and optical magnification. I would say add on to that, let your neurosurgeons know that you're going to be doing a high risk case, right? So instead of going and searching for all these things for your nursing staff once you've poured the dura, have them available. As Taemin mentioned, current evidence supports primary suture repair with adjuvant patching when needed rather than reliance on sealants alone. So that's intraoperative readiness. Standard documentation and communication. So if you have a tear, it should be clearly put in either an epic note or your op note. That should be about the location and size of the defect, the mechanism of injury. Was this during exposure, instrumentation, or osteotomy? What was your repair technique utilized? What was the result of your intraoperative Valsalva? What is your drain strategy, as mentioned by Taemin? What's your postoperative immobilization plan? And have you documented things with the family so they know? Postoperative surveillance plans that are already managed. You're looking for positional headaches, nausea, or photophobia. You're looking for wound drainage, mostly clear wound drainage. and neurologic changes. These are actually pretty rare. If you're having clear drainage out of a drain at children's, we do use beta transferrin a lot. As Taemin mentioned, it can be a little bit of delayed in the time you get it back, but it really can help if there's a question about things. So clear escalation pathways should be defined for imaging, wound evaluation, and return to the operating room. And again, protocols, we don't really have defined protocols that are posted in Epic or on the wall, but you can use AI to define an Epic protocol. You can find these protocols in a lot of degenerative lumbar spine literature. I think the most important thing, you either have a protocol, you have a thought process where you're going down a decision tree with either yourself or having your partner manage a problem if you emotionally can't really make the decision. I will mention a little bit on delayed presentation. We see this not a lot, but occasionally we will see this in an AIS patient. Someone comes back at 2 weeks or 3 weeks call, they're saying positional headaches. I think we see it more in AIS patients because you're using more screws, right? But we early mobilize these patients. So patients in the past have been at bed rest 2 or 3 days. Now with ERAS programs, I think they get up, and the tendency maybe a dural neck that you got with an awl or a screw turns into something that's leaking. If these patients present on an outpatient basis or even in the hospital, we use a contrast. It's got to be a contrast MRI of the brain, and you're looking for meningeal enhancement, where you're looking for cerebellar tonsillar going down. These are sort of the mainstay of a patient that's an AIS patient that you're worried about the dural tear. If they have those things, you really need to consider a CT myelogram, looking at all your screws and seeing if you can find out where your leak is happening. If you do that and you find somewhere to leak, you can think about a blood patch. So Glotz wrote that paper at Children's a long time ago. Event review and classification, I'll move on. All CSF leaks should undergo a formal review in your M&M conferences and quality conference structures. Events should be categorized as preventable, technique-related, anatomy-related, or unavoidable. And dashboarding and clinical monitoring. I think it's probably more important with neurosurgery or high-volume myelo centers because it's such a low-frequency thing. But I think dashboarding, as Michelle has shown, for every part of what we do in spine surgery is super important to improve your quality. So in summary, CSF leak presentation and pediatric anesthetic spine surgery should be operationalized at a high reliable system, looking at preoperative risk identification, standardized safety behaviors, evidence-based repair strategies, structured documentation and monitoring, and then quality review. That's it.
Awesome, Dr. Hedequist. Thank you. I think that summary was a really nice reframe, that it's not really an isolated technical event and the system's pretty important. We have one question. There was a question in the Q&A about concerns about epidural brain bleeds from the CSF leaks. Any experience with that, or how we work that up?
I'd have to refer to Steve or Taemin about that.
Oh, sorry, answer. I think in adults, I don't think we see it as commonly in kids, just because there's less atrophy. In adults, there's more cerebral atrophy. So I have certainly seen it where people presenting with like chronic or subacute subdurals as well. So I think in adults, especially, be more careful.
And usually it's in the older adults too, right? Yeah. So not typically in the 40 to 50-year-olds, but the 70 to 80-year-olds, we can sometimes see that.
Dan, I was really impressed with that structured template for your op note. I think that covered all the bases. I have to admit, I haven't been as specific about the situation in the moment, but that's an awesome way to document it. You know, the other thing I would add is good communication with the team that manages the patients on the floor, whether it's PAs, APNs, or residents. I think they need to know what happened in the OR and what you're going to do each day. But that was fabulous.
Okay. I think we're right on time. So thanks again, Dan. Last up is Dr. Pat Cahill from CHOP. He's going to bring it together with some case-based pearls and scenarios where the typical rules may not apply.
Yeah, great. Thanks, Arun and Sukin, for having me. I'm going to be talking about a couple special cases where, the rules are a little bit different. So we're talking about intrathecal morphine and epidural morphine administration for post-op pain management and AIS PSF, and then also the special case of VBT and a couple cases related to that as well. So Intrathecal morphine, it's one of those things that's been around for a long time. It's not widely used, but the people that use it are very vocal adherents to this modality. And fortunately, they've also shared their experience with that in publications. So this first publication is the only case I could find. I know Mike referenced a little bit about potential CSF leaks in this group earlier on. I found one case. It's a relatively rare thing for patients that have either a post-op epidural morphine catheter or a single shot intradural injection of morphine. So fortunately, very, very rare. Some of the reasoning, this one paper mentioned that maybe it's because of the small gauge of the needles that they use that allows the dura to sort of instantly seal around it. I think also it's because these are injected or inserted below where we've done anything else to disrupt the normal layers that protect and sequester that CSF. So the lamina is still intact. We haven't done any pontes. We haven't placed any screws adjacent to the canal. We haven't released the ligamentum flavum and so on. So I think it allows the CSF to be relatively sequestered. And if you were to have one of these problems, I think then the treatment also benefits from those structures still being intact, which is that I think this would be a good group for a blood patch. But again, I don't have any experience with that particular intervention for this particular indication, nor does it seem like there's a lot of concern about that. The other interesting thing for the people that use those types of modalities for post-op pain management is that they don't seem to have any specific restrictions. So I did some calls to some of the sites and try to find out, are they keeping these patients flat in bed for a day or two, or even after the catheters come out if they're using an epidural catheter? And it seems like the answer is no. They're letting these kids get up and move, with the exception is that they're keeping their Foley until about 4 hours after the epidural catheter is removed, just because they've been seeing some urinary retention. But that's about it. So it seems like a pretty nothing burger in terms of the risk of CSF leak, at least in what's published and what I'm hearing from those people that are utilizing it. Now, the opposite is not true with VBT. We are hearing and seeing reports of CSF leak with VBT, and it's a little bit of a different animal than what we're seeing and hearing with posterior spinal fusion for AIS. So there's about a 1% to 2% incidence reported in most of the major series, which again is probably orders of magnitude higher than what we're seeing with the standard posterior spinal fusion for AIS. This is one of the images of a little collection of CSF. You can see it's relatively far away from the spine. It kind of found its way through some layers here. Again, blood patch was utilized in a couple situations. Revision screw surgery is not uncommon. And the problem here is that a lot of these either are in the chest or communicate with the chest because the diaphragm is taken down, and there's a constant negative pressure that's going on in the chest with each breath. And so that's drawing CSF through whatever breach there is and not allowing that dura to heal. This is one of my patients. She had the tethers placed. I noticed this screw being a little posterior here, so I revised it before the end of the case, even before we placed the tether. And I just filled that with some hemostatic agent. And unfortunately, on post-op day 4, she developed a headache. She had shortness of breath and a cough, and sure enough, she had a chest full of CSF. And again, this is probably because this negative pressure that happens with breathing was continuing to pull that in. But there's also the other concern that for some of these patients that are presenting longer term, that maybe the dynamic nature of vertebral tether allows the dura to be continuing to slide across the threads that are in the canal. So with a posterior spinal fusion, we might be satisfied with a couple millimeters of threads protruding into the canal and tickling the dura. However, with a vertebral tether, that serves as sort of like a constant irritant in sawing through the dura, and probably not any amount of canal penetration with our screws is acceptable. My patient fortunately recovered, but we did have to use a lumbar drain. And I think that's the other take home I would have, is if you have a CSF leak with a vertebral tether, not only should you revise the implants so they're no longer even anywhere near the canal, but consider a lumbar drain early, because I don't think you're going to get this to stop draining otherwise. This is another one of our colleagues who published his case report, very similar to what we just saw in the last talk. We see some enhancement here. We see descent of the cerebellar tonsils into the spinal canal. Very typical. This was a 3-month post-op presentation. And again, just a few millimeters of threads right into the canal. This is something we really have to be on the lookout for. We cannot accept any canal penetration. And also the neurologic symptoms will be different. Of course, we're in the ventral part of the spinal cord, so we're going to be more concerned about some of the sensory changes than we would see in the posterior part of the spine. Thanks a lot, guys.
Thank you, Pat. Shocking that it's an order of magnitude higher with BBT than posterior spinal fusion. That's disturbing.
Yeah.
We don't
Steve,
have
any thoughts
questions
on that? Steve, you look like you want to chime in there a little bit.
Oh no, I just wonder if it's detected more often because it, like you said, it goes intrathoracic, and so you can't really ignore it as much.
Yeah, so maybe the take home is that it's a clinically significant CSF leak is an order of magnitude higher because, again, posterior spinal fusion is much bloodier, and that's sort of a blood patch in and of itself is just the surgical field of a posterior spinal fusion. So, yeah.
Great. We've got a question in the chat. It wasn't directed to anyone in particular, but what about placing the bed in Trendelenburg? This question is from Jeff. Placing the Trendelenburg position to allow egress of CSF during repair of a lumbar durotomy. So not just flat bed rest, but go negative. It'd be a similar Taemin to your 30 degrees of elevation for cervical, right?
Right. So in intra-op, so when I do tethered cord release, actually, I'll put the patients in Trendelenburg before I even open the dura. So it does help. But for thoracic and cervical, I don't think necessarily you need to change the positions for most of the time. But lumbar, it does help at least for me.
Yeah, and you brought up caffeine earlier. I wanted to touch on the medications. What about mannitol? What about just regular hydration and any other medications beside the Diamox? And what's the evidence? Why does caffeine even work?
So caffeine is thought to reduce CSF production. So it can help with some of the kind of the pressure related sensations in terms of the positional headaches. Diamox is similar. I had a patient who was dumping out 500, 600 cc's out of had a baclofen pump. We took the baclofen pump out. There was no clear CSF leak intra-op, but was putting out 500, 600 cc's. And so that was a patient where I was actually thinking, he might need an EBD because he had a T2 to pelvis. There's no good place to put a lumbar drain in. But put him on some Diamox. That actually helped, but that's just an N of 1. So I don't really have much evidence to support it, but it just happened to work for that patient.
Well, this was an incredible hour, Harvey. If we can bring this home and end it before the hour, I think this was fabulous. We learned about the risk factors. We learned about prevention, management, some of the closure techniques, some of the new technology, and some of the esoteric things about CSF leaks. I think this has been outstanding. I want to thank our panelists for great talks, staying on time. We have some future webinars coming up later this year. One of them is on BBT, the optimal patient parameters, on August 20th. The other one's on Scheuermann's kyphosis on October 29th, with, again, a world-known faculty and expert panelists. Next. If you enjoyed this webinar and other productions from the Harm Study Group and Setting Scoliosis Straight Foundation, you'll find us on our YouTube channel. After probably a week or two, this webinar will also be on our YouTube channel where you can review it and archive all of our previous content, including patient education information as well. And this QR code will take you to that YouTube channel. The Surgeon Performance Program has been endorsed by both POSNA, the American Board of Orthopedic Surgeons, as an incredible way to improve your practice. This is a surgical quality improvement database powered by the Setting Scoliosis Straight Foundation. It's free. And it'll allow you to benchmark yourself against other surgeons, as well as surgeons of the Harm Study Group, and see how you can improve certain parameters of your operative skill. It's an automated dynamic dashboard reporting. This QR code will take you to our associates in the Harm Study Group and Setting Scoliosis Straight Foundation who administer the program. They'll get you set up, and it's a great way to start your career and follow your progress. And finally, if you have enjoyed this webinar, we would appreciate you making a donation to the Setting Scoliosis Straight Foundation. Our efforts to improve both surgeon education and patient education and advocacy go a long way, but we can do more with your help. This QR code will take you to the Setting Scoliosis Straight Foundation website. You can donate online, or you can text scoliosis to 41444. Thank you for attending. You're going to get a survey right after you close your window from this webinar. And if you have anything else, please contact us either through our website or through the email listed here, info@sshsg.org, or our website, www.settingscoliosis.org. And we want to again thank our sponsor of this webinar, Baxter. Have a great night.